are familiar with. So I'm just going to start with a little bit of description before I start with the viva. And so pathology in children, they vary with age. I have just, for better understanding, I have divided the conditions in medical disease and surgical conditions. Medical disease are different in children in comparison to adults. They also vary with age, and they're different when children grow up. So preterm infants will have different medical diseases in comparison to term infants and later in life. So I'll start with the preterm infant first. I'll show you some examples of hyaline membrane disease and its complications, various tubes and lines. In term infants, I'm going to show you thymus, various appearances of thymus, transient tachypnea of newborn, meconium aspiration syndrome, and various types of pneumonias. In surgical conditions, I'll cover congenital diaphragmatic hernia, CPAM, lobar hyperinflation, and mediastinal pathology. So technique of acquiring X-ray in children is different to that of an adult. AP supine is acquired when children are unable to sit up, AP sitting when they can sit, and standing PA when they are able to stand. So therefore, the appearance of mediastinum varies with age and how the X-ray has been acquired. So normal cardiothoracic ratio in children can be more than 50%, and it can sometimes be up to 60% also if they have not taken a deep breath. CTR in supine, 1 minute, sorry. CTR in supine AP radiograph can be up to 60%. Also, thymus is enlarged in children and can be seen on both sides of mediastinum. It reduces in size after 5 years and is not visible after 15 years. Normal thymus is homogeneous and does not have any mass effect on trachea. That's how you recognize it. Ultrasound can be used to confirm in doubtful cases. So with this overview, I'm going to start with my first case. So candidate number 1, please, if you would like to describe this.
Okay, so frontal radiograph of a child. There's an ET tube in situ, which appears to be in appropriate position. There also appears to be an abdominal, an umbilical catheter. Regarding the lungs, they have bilateral symmetrical ground glass opacification with reduced lung volumes. If this was I can't see any pneumothorax or pneumomediastinum. And if this was a premature patient, my top differential would be acute respiratory distress syndrome.
Yeah, or hyaline membrane disease, same thing. Yeah, very good. Very nice description. And this, would you like to go on to the other one also? What's the pattern of the findings in this one?
Okay, yep. So frontal radiograph of a neonate. The NG tube appears to be in satisfactory position, and the lungs bilaterally appear to have a coarse reticular pattern. There's no pleural effusions or pneumothorax. Differentials for this again could be hyaline membrane disease or complications of it, such as chronic lung dysplasia if the patient's slightly older.
Okay, it's day 0.
Day 0. Would correlate with the birth history.
Yeah.
If they've had if there was any complications, or if it was a traumatic birth. If it was a premature child, then it will again be hyaline membrane disease.
Yes, that's correct. And that's another pattern of hyaline membrane disease. And so this was indeed a child. The first one was preterm infant with hyaline membrane disease. So the radiological features of hyaline membrane disease, first the clinical features, the children are actually preterm child. They present with tachypnea, chest wall retraction, and grunting. Radiologically, we see small volume of lungs, which you rightly described, and with rib crowding, because the volume is less, there is rib crowding. There can be ground glass opacification of lungs, or they can be reticulogranular opacity. This is the buzzword which the examiner would like to hear if you see such a pattern. The second radiograph showed this reticulogranular opacity. So these are small granularities which we can see in some cases, and granules are because of the atelectatic alveoli. They haven't had chance to expand fully, and that's why the granularity is there. Or it can just be interstitial edema, and we will not see these findings once the volume increases and the patient is on ventilation. They just disappear after the surfactant has been given to the patient. So why does it happen? It is due to deficiency of a phospholipid complex known as surfactant, which is synthesized by type 2 pneumocytes. It coats the alveoli and lowers the surface tension of the alveoli, and therefore they remain expanded. And it is leading cause of morbidity in preterm infants who are less than 36 weeks and less than 2.5 kilos. Okay, next case for you, candidate 1.
So this is a frontal radiograph of a child. There's an ET tube which appears to be in satisfactory position, and there's also a tip of a tube arising from the abdomen in the right upper quadrant. So the lungs have a coarse reticular pattern, predominantly in the upper and mid zones, and slightly less severe in the lower zones. It appears to be quite symmetrical. The lung volumes appear to be preserved. Normal cardiomediastinal contour. There's no pneumothorax or pleural effusion. So again, I would correlate with the patient's birth history and if they're premature or not, and how old they are.
Preterm infant on ventilation.
Okay. So given that the patient's on ventilation and was preterm, I'll be concerned about a complication of hyaline membrane disease, such as chronic lung dysplasia or pulmonary interstitial emphysema.
Yeah. Which one do you think is going on here?
Chronic lung dysplasia.
There is a tube in here.
So it has a tube, so pulmonary interstitial emphysema.
Yeah, it's more of leucine. Sometimes it's difficult to interpret, that what is the problem. The leucencies are a problem or the opacification is a problem. In this case, it's more of leucencies, and it is PIE. So preterm infant on ventilation with sudden deterioration, they usually present like this, and this is PIE indeed. So what happens in PIE? It occurs due to rupture of alveoli and the air escapes in the interstitium. And then it can go into the pleural space or mediastinum depending on how much it is. And the cause is positive pressure ventilation. So the settings in the ventilator have to be adjusted once you see this, and the pediatricians have to be informed about it. So you describe it. Multiple leucencies, small leucencies are demonstrated, and in the interstitium, and probably it's pulmonary interstitial emphysema. You would alert the pediatrician about it. So you would like to describe this also?
Yeah. So frontal radiograph of a child. The ET tube is in satisfactory position, as is the nasogastric tube. There is quite dense lungs bilaterally with a well-defined area of lucency in the right lower zone. I can't see the heart shadow very well due to the increased opacification in the lungs. And I'm told this is a day one child. So the lung volumes appear to be preserved. And is the child preterm or?
Yeah, preterm child.
Okay. There's also some areas of lucency in the areas of increased opacification. In the day one preterm child, if the child's been on ventilation, again, it will be pulmonary interstitial emphysema, will be my differentials, as well as I think he'll be too young for bronchopulmonary dysplasia. The other potential being meconium aspiration.
Okay, yeah, wonderful. See, there is lucency overlying the mediastinum, and this is mediastinal air. Okay, also it seems to be tracking along the vessels here, and there is a blob of air here, which is likely to be a pneumothorax, an encysted pneumothorax. And if you want to confirm the pneumothorax, how would you confirm the pneumothorax?
I guess, can you do lateral debutica? Can you change the position of the child and see if the air moves?
Wonderful. Yeah, you can do decubitus view to confirm the pneumothorax. And there are two positions in which you can do the decubitus. One is decubitus is horizontal beam X-ray, and you can do in lateral position when the children can be turned in lateral position. If they are too sick to be turned in lateral position, then we do shoot through like this in supine position only. And in this case, we can see air anteriorly. Air would move anteriorly. So air is here, so which sort of confirms that there is free air in the pleural space. And this is pneumothorax, and this is all due to PIE. There is patchy opacification and opacification and lucencies, and the air has leaked into the mediastinum as well as the pleural space. Okay, your next case.
So frontal radiograph of the chest in a child, the ET tube and N tube are satisfactory position. There's diffuse ground glass opacification of the left lung, with some areas of lucency in the lower zones in the peripheral aspect. In the right upper zone, again, there's diffuse homogeneous increased opacification. The right and lower zones, I can see areas of lucency with some patchy areas of increased density.
Yeah.
Looking at the ET tube, I wonder if it's gone down the right main bronchus. It appears to be slightly lower than I would expect it to be. So I'm not sure if this is one of the reasons why the patient's having increased oxygen requirements. If they've had some sort of, if they're only ventilating one of the lungs. I'm also not sure if there's, within areas of lucency, I'm not sure if there's a small pneumothorax as well.
You mean on right side or left side?
On the right side.
On right side. Yeah, fantastic that this is opacification, right upper zone, and also the entire left lung. And as you said, it's absolutely right that the tube is in right main bronchus. The lung is not normal lung, and the patient probably has hyaline membrane disease or its related complications. And the tube, in this case, we can't see what is going on in the lung, but what we can see is that lung is not normal, and the tube is in right lower lobe bronchus, and therefore there is collapse of left lung and right upper lobe. And this is causing opacification of rest of the areas. Can I take you back to this one? In this one, examiners like to ask when would you do, what's the advantage of keeping the patient supine, or what's the advantage of keeping the patient in lateral position? Do you know about this?
So I suppose in the lateral position, it's useful if they have, if you're trying to look for free air in the abdomen or a pneumothorax in the chest.
Yeah. So lateral position is useful, is more useful because it tells you the side also where the air is there. Otherwise, you can see the side on AP radiograph, but the dose is less in lateral position, whereas the dose in this supine position is much more. So that's the advantage of lateral position if the child can be rotated in lateral position. So yeah, ET tube was in right main bronchus with collapse of right upper lobe. So can I start with candidate number 2 now? Okay, can you hear me, candidate 2? Hello.
Yes, I can.
I've just unmuted candidate 2. Candidate 2, over to you. Thank you, candidate 1.
Thank you, candidate 1. Okay, so we have covered hyaline membrane disease and its various complications. So now we are moving on to tubes and lines in pediatric radiology. So tubes and lines which I used, first is endotracheal tube, and there can be complications related to its position, like one we saw just now, and umbilical arterial catheters as well as venous catheters. So endotracheal tubes in children can be as small as 3.5 millimeter in external diameter. Positioning them and retaining them in position is very difficult as small neonates, as they are non-cuff tubes, so they cannot be retained very well. So they can easily be pulled up by neck extension, prone positioning, or lateral rotation of the head. The optimum position of the endotracheal tube is 1 to 2 vertebral bodies above the carina, which is at the level of T1 to T3, ideal position T2, or inferior margin of the clavicle. So this is somewhat, inferior margin of the clavicle and at T2 level. And you can't see the trachea very well. Apologies for that. But it is well above the carina. So going on to the umbilical catheters, they provide convenient and minimally invasive access to arterial and venous system in first 7 to 10 days of life. They can be associated with complications, often related with their malpositioning. Distinguishing UAC from UVC will require abdominal radiograph. Umbilical arterial catheters allow non-invasive monitoring of arterial blood gases, particularly useful in neonates with cardiopulmonary disease. An ideal position of arterial catheter is, one is high position, which is a preferred position because they are retained very well in this high position. It is between T7 to T9, and there is a low position also if they cannot reach the high position. Low position is L3 to L4. The idea is to avoid the major visceral arteries, which are mesenteric and renal arteries, because thrombosis can occur due to the foreign body mechanism in that region. So keeping all this in mind, we'll review the cases. A few words more about umbilical arterial catheter. There are two umbilical arteries, except in some chromosomal anomalies, and the course of umbilical arterial catheter is through umbilical artery into the internal iliac artery, and then into the common iliac artery, and finally into aorta, and then at T7 to T9 level. Umbilical venous catheters, they provide large bore central venous access for about 10 days. Ideal position is at the junction of IVC and right atrium, which is at the level of T8 or T9. Complications which may be associated with umbilical venous catheter are sepsis and portal venous thrombosis. So the course of umbilical venous catheter is umbilical vein, then into the left portal vein, ductus venosus, and then left or middle hepatic vein, and finally into IVC, and then it is positioned at the level of IVC and right atrial junction. It appears as a straight line on frontal radiograph, and it is anteriorly positioned, whereas the arterial catheter is posterior catheter. So on this radiograph, you can see the position of two catheters. This is UVC, and UVC go on frontal radiograph appears as a straight line and is positioned at the junction of RA or in proximal part of RA. UAC, on the other hand, forms a loop, umbilical artery, and then into the internal iliac, and then into common iliac and aorta, and then it is positioned at the level of T7 or T8, T9. And that's how it looks on the lateral radiograph. UAC is posterior and UVC is anteriorly positioned. Okay, first case for you, candidate 2.
Okay, so I'm provided with the babygram in which I can see multiple lines and tubes. First of all, I can see the endotracheal tube, which is slightly downwards, and it's at the level of T4. So I will ask the emergency team to retract it and pull it up, while the umbilical artery catheter, I can see is both umbilical artery catheters and UVC are in malposition. So if I trace down the umbilical artery catheter, it is at the level of
Sorry.
Okay.
Yeah.
So umbilicus venous, umbilicus arterial catheter is at the level of T8, and is distal to stomach. So again, that's the malposition umbilical artery catheter, but UVC is also the straight line, which I can see is going into the superior vena cava. The upper tip is in the superior vena cava, so it should be in the right atrium. So I will ask the emergency team to retract back and put in the IVC or in the right atrium. And yes.
Wonderful. See, this is at T8, isn't it? So it is normal, isn't it?
Yes.
Yeah.
Okay.
So this is normal. And this is the UAC or UVC?
UVC.
UVC. Where do you think it is going?
It's in the superior vena cava brachiocephalic.
Okay. Yeah. Lovely. So yeah, it is malpositioned, and you would advise the clinical team to retract it and position it in the correctly. So yeah, UAC is at T7 and it's absolutely fine. UVC is in jugular vein and it's high, and it needs to be repositioned. Okay, next one for you.
Okay. Again, I'm provided with the baby cram in which multiple lines and tubes are noted. So I can trace down the umbilical artery catheter in the normal position at approximately T7, T8, sorry. And rest of the, what else? So I can see the nasogastric tube is well placed and is distal and at the distal part of the stomach.
Mm-hmm.
And the straight line, which can I appreciate, it's the umbilical venous catheter, which is in the which upper tip is in the left subclavian artery or vein.
Lovely, wonderful, yeah.
So I will definitely tell the clinical team to, and that's that malposition, and they should be retracted back in the normal position.
Yeah, so this is the NG tube, and this is the venous catheter, which is on right side. It is sort of in okay position, and it's in RA. And this one is the arterial catheter. You can't see the distal part of the catheter. That's why we try to include pelvis always, so that there is no confusion. So this has looped around, and this is the arterial catheter which is going into the aorta, and through aorta it is extending into the left subclavian artery. Very well described.
Thank you.
So yeah, it is in left subclavian artery, UAC. Okay, next one for you.
Okay, so 3-week-old premature with bradycardia, anti-saturation sepsis. So that's the frontal projection of neonate, as I can't see any ossification center of the humeral ossification center. So I can see there is opacification of the right upper lobe, involved right upper lobe, and there is decrease in the lung volume on the right side, while left lung is normal to me. The main part I can see there is endotracheal tube is lower down, and as baby neck is flexed, it should be less than 3 centimeter, but it is more than the 5 centimeter in the flex position. So definitely it's in the wrong position, malposition. So it should be positioned well, and it should be informed to the clinical team, as it obstructing the right upper lobe bronchus.
Wonderful. Yeah, it is obstructing indeed, and it should be pulled up. What is happening in rest of the lung? What else is going on in the lungs?
Okay, the breast of the lung.
It doesn't look normal?
No, it doesn't. So it's there is reticular nodular shadowing on the left side, and I can't see any pneumothorax. Rest, and there is decrease in the is there any hyperlucency? No, sorry, I can't.
Okay. No worries, no worries. The problem still remained, and the patient, when the patient was 5 weeks, still unwell. And now, can you make out what's going on before I take over?
So as the patient was okay, so it could be there are translucencies. I can see the lucency, linear lucencies in both of the lungs. So either I will ask for the previous history if the child is on any ventilation. So so on the basis of these findings, yes. So it first differential is pulmonary interstitial emphysema.
Okay, what is
could be a sepsis? Okay.
Okay, sorry, candidate 2. I have to take over just
Yes.
so that we keep up the time.
Yes.
Okay. Yeah. So what is this?
That's the foreign body.
Anything else?
A surgical clip.
A surgical clip for what?
Any cardiac issue or.
Yeah. So this is being shown to you so that you're familiar with this. This is PDA clip. This is PDA clip, and PDA is open in preterm infants. So this gives you a clue that the child was a preterm child. Okay, this is a big clue.
Okay.
Okay. Besides, 5 weeks old child, the humeral epiphyses are not still seen. They are seen definitely by 41 weeks. So the child has to be preterm child. So they may not be seen at 37 weeks, but they are definitely seen at 41 weeks most of the time. Okay.
Yeah.
So and there is some opacification in the lung in a preterm child. Bronchopulmonary dysplasia or chronic lung disease occurs due to ventilation. Okay, so that's what is going on. And this was the finding on this one also. And you correctly described that endotracheal tube is extending up to the carina, and this is causing obstruction of the right main bronchus, right upper lobe bronchus, and therefore the collapse of right upper lobe. Okay?
Yeah.
So yeah, this is chronic lung disease. This is another case of the same condition, and we can see the appearance of or opacification, irregular opacification in both the lungs, and consolidation or collapse of right upper lobe. And PDA clip as well. This gives you a clue that the child was a preterm child, still ventilated. So these children, they are prone for repeated infections, and they keep on attending the A&E and the GP clinic because they are more prone. The architecture of lung parenchyma is distorted, and they keep on having infections.
Right.
So and they come with apneic episodes, infective episodes, all those things. So bronchopulmonary dysplasia or chronic lung disease with right upper lobe consolidation in this. So far I've covered medical diseases in preterm infants, hyaline membrane disease and its various complications, and tubes and lines. So I'm moving on to medical diseases in term infants now, which are TTN or transient tachypnea of newborn, meconium aspiration, and various pneumonias. So first case for you, candidate 2, you're still there?
Yes, I am. Okay, so I'm provided with the frontal projection of a skeletally mature or neonate in which I can't see any ossifications and humeral ossification center, in which I can see the lung volumes are increased bilaterally, and there is and the lungs appear translucent, and there is mild granularity, which is not very specific in this. So I will correlate with the birth history of the child. If any cesarean or if any cesarean delivery, then first differential on this basis of increased lung volume is transient tachypnea. Or
what happens in transient tachypnea of newborn?
So there is an increased volume of the lungs plus granularity, diffusely involve both lungs with the granular appearance. And what?
And what's the pathophysiology in this?
Because there is no squeezing, as we do in the normal birth. In cesarean, there is no squeezing of the lungs, and the water retention is there. Mm-hmm. So fluid will be in the fissures, and we can see pleural effusion.
Okay, so they can be small pleural effusions. Yeah, wonderful. So this was a term infant. So this was definitely a term infant. See, humeral epiphyses are not there. So they may not be there at 38 weeks and 39 weeks. So it is a good way to describe that you don't see humeral epiphyses, so you are not sure it can be a preterm infant, but it is not, guaranteed that they will be a preterm infant. This was definitely a term infant, and as you rightly said, the lungs are quite expanded and they show some streaky opacities. That's how we describe them. Streaky opacities, rather than describing them as reticulogranular, because reticulogranular opacities is, you didn't use this term, I'm just trying to tell everyone that reticulogranular opacity is a term reserved for hyaline membrane disease and shouldn't be used for other diseases. And so in TTN, what's going on? It's a wet lung disease, and it's due to retained fetal lung fluid and is common in infants born with cesarean section. Radiologically, we see increased interstitial markings due to interstitial fluid. And there is fluid in fissures. It can be associated with pleural effusion and hyperinflation. So this is hyperinflated as opposed to hypoinflated lungs in respiratory distress syndrome. But yeah, interstitial markings are common to both. Okay, can I have candidate 3 now, please? Thank you, candidate 2. Yes, candidate 3, can you hear me? Yeah, would you like to describe this, please?
Hi, hello. I think I'm unmuted now.
Okay.
This is a frontal chest radiograph of what I'm told is a term neonate. There is a appropriately sited nasogastric tube in situ. The lungs bilaterally demonstrate ill-defined, peripherally predominant opacities.
Yeah.
And then biapically there's increased translucency.
Yes.
Potentially indicative of consistent with small pneumothoraces.
Wonderful.
And there's potentially mild overinflation in the context of a term baby, and assuming that there is some respiratory distress, which is why a chest radiograph has been performed.
Yes.
Appearances are likely to be consistent with meconium aspiration syndrome.
Wonderful, fantastic description, and you just cracked it. Yeah, so there is, this is a case indeed of meconium aspiration. So what's happening is there is bilateral opacification, patchy opacification. It's not very symmetrical. It can be very asymmetrical also. In this case, it is fairly symmetrical, and it can be associated with pneumomediastinum and pneumothorax. What's the pathophysiology? I'm just going to discuss it. Do you know the pathophysiology, candidate 3?
So meconium aspiration syndrome tends to be associated with traumatic births. So often there's a history of meconium-stained liquor, and then the baby breathes in parts of meconium that it's passed due to fetal distress, and this meconium is sticky and it causes blockages in the small airways, and sometimes you get like valve type effects with distal overinflation and air leaks, which is why perhaps we have the pneumothoraces here. And then also atelectasis and kind of, alveolar blockage, which is where the opacities would be coming from.
Yeah, super. Very well described. And this is another case, just a different kind of appearance. So they may not be symmetrical. They are allowed to be asymmetrical completely, depending on which side the meconium has gone. So in this case, there is pneumothorax only on left side, and there is patchy opacification in the right lung. So, and usually there is history of a term born with respiratory distress born by emergency cesarean section. So that kind of history is usually available to us. And you can ask the examiner, just if you are in doubt, you can always ask, was the child born with in emergency or fetal distress? So, yeah. What causes meconium aspiration? The causes is partial or complete bronchial obstruction is along with chemical pneumonitis. That's what happens due to meconium. That one, it causes chemical pneumonitis. Secondly, it blocks the bronchioles. So radiologically, we can see bronchopneumonia as a result of chemical pneumonitis. And as a result of blockage, we can see areas of subsegmental atelectasis and combined with areas of overinflation. And due to overinflation, sometimes there is a leak of air into the pleural space or mediastinum. That's why we see pneumothorax and pneumomediastinum. This has very high mortality. Actually, if it is significant aspiration, mortality can be up to 25% also. So it's not a very good disease to have. That's why they do cesarean section quite urgently. So I've covered term infants, TTN, and meconium aspiration. And now I'm moving on to the surgical conditions, and I'm going to discuss mediastinal pathology and pneumonia separately. So in surgical conditions, I'm going to cover congenital diaphragmatic hernia, CPAM, and lobar hyperinflation predominantly. So candidate 3, stay with me. And if you would like to describe this.
So I'm presented with a babygram of a neonate, 3-month-old neonate. The striking abnormality is in the left hemithorax, where lung markings are not well seen, and there is rightwards mediastinal shift with tracheal deviation and shift of the heart and the cardiothalamic contour towards the right.
Yeah.
The left lung, the left hemithoracic space, just has a diffuse, homogeneous, quite ground glass density.
Yeah, wonderful.
I think the most likely cause for this is congenital lobar overinflation.
Sorry, say that again.
CLO or congenital lobar overinflation or emphysema.
Okay. And what else would you think? Any other differential you would like to keep?
Well, I mean, this could represent a tension pneumothorax, but without any history of a reason for that.
What you have described is there is shift of mediastinum to right side, and there is some haziness in the left lung, and which is so haziness would be caused by
fluid, presumably.
Sorry, say that again.
Fluid.
Fluid. What can cause fluid in such way?
I mean, that could, if that's not lung, I think I can see a good left hemidiaphragmatic contour, but that one of the differentials would be a large left-sided diaphragmatic hernia, and that is actually viscous.
Okay, how would you proceed to investigate it further and to confirm?
So, a chest ultrasound would probably reveal what is beneath the pleura.
Okay, yeah.
And many of these patients receive cross-sectional imaging as well.
Yeah, you would like to reserve cross-sectional imaging if you can do with ultrasound and get the diagnosis. Anything else you can do clinically or?
So you might auscultate bowel sounds if we think that there's in the chest.
Yes, yes, you can auscultate.
Or you could pass an NG tube and see where it goes.
Wonderful. Yeah, that's what I was trying to get from you. So that was what was done in this case. So NG tube was passed, and what can you see now?
Okay, so a bit more clearly seen now. So this is a frontal chest radiograph of an infant. There is rightwards mediastinal shift due to the presence of a large air-filled viscus in the left hemithorax. The NG tube passes into this, and I think this represents the stomach due to a large congenital diaphragmatic hernia.
Wonderful. Okay, so yeah, it is indeed diaphragmatic hernia, slightly confusing, and this actually presented at the age of 3 months. So there was no indication in antenatal ultrasound. Usually they are detected antenatally nowadays, but there was no indication, and this child presented at the age of 3 months. Quite confusing, but yeah, that's how we proceed, you know, that suspect diaphragmatic hernia, auscultate, and do ultrasound scan, and then put NG tube and insufflate some air. And if you can confirm the diagnosis at this, patient straight away goes for surgery. And usually they are associated with hypoplasia of the ipsilateral lung, because the lung hasn't had chance to develop completely in the antenatal period. So this was the post-op X-ray of the same patient. So this is the next one for you, and then I'm going to sum up all the findings.
So this is a frontal chest radiograph of a term neonate. Just in terms of tubes and lines, there is an appropriately sited endotracheal tube. There is a NG tube, which I can see passing just below the diaphragm, terminates around the level of the left pedicle of L1, and there is an umbilical catheter, although without the abdomen I can't see where that goes, as well as a right internal jugular line. The striking abnormality is gas-filled, what appear to be bowel loops within the left hemithorax, causing rightwards mediastinal shift and extensive compression of the normal thoracic structures. And the appearances are consistent with a large congenital diaphragmatic hernia.
Any differential you would like to keep in such cases with this kind of appearance?
So these, I think I can see mucosal, essentially mucosa around the air bubbles on the left, but other multicystic lesions in the lung, so it could be a CPAM, congenital pulmonary airway malformation.
Yes, yeah, you should keep that differential always. Yeah, this was indeed a case of congenital diaphragmatic hernia, as you rightly described, and most of the time you would see this kind of appearance rather than the initial case which I showed you. So, and these are bowel loops, and if you did auscultation, you would hear the bowel sounds, and if you did ultrasound scan, you would see peristalsis. And yes, so that's how it is confirmed, and then it goes straight for surgery. So congenital diaphragmatic hernia, 90% are Bogdelog's hernia, and on left side, 5 to 10% would be Morgani's hernia, and the differential diagnosis which you should consider is CPAM and lobar emphysema. Further investigations, as we already discussed, can be ultrasound, bowel loops in chest with peristalsis, NG tube insertion with contrast or air, and these can be associated with gastric volvulus and unilateral or bilateral lung hypoplasia. This is just out of interest, you know, that these can be detected on antenatal ultrasound first and then referred for MRI scan. This is one of the fetal MRI, and we can see that bowel loops are seen in the hemithorax. I guess this is the right side, or difficult to say on this one. Another case when you can see that there is a diaphragmatic hernia posteriorly, and probably the stomach is herniating in this case. So next one for you, candidate 3. Are you with me, candidate 3?
Hello.
Hello. Yeah.
Sorry, I got muted again. Sorry, so this is a frontal chest radiograph of what I'm told is a newborn infant patient. The striking abnormality is in the left hemithorax, where there is increased translucency and absence of the normal lung markings with enlarged cystic spaces. My primary differential is a CPAM on the left, but I would also include in the differential diagnosis large congenital diaphragmatic hernia. I would recommend that the patient could have an ultrasound scan, cross-sectional imaging for further evaluation.
Okay, lovely. Which part of the lung CPAM involves more? Which lobe of the lung are involved more in CPAM?
I think it's the lower lobe. I think the left lower lobe.
Super. And how many types of CPAM do you know of?
Oh, I believe there's a classification, but I don't know it off the top of my head.
Not to worry. Not to worry. I'm just going to, explain it in a few minutes. So yeah, it is CPAM of left lower lobe, and which is congenital pulmonary malformation. And differential diagnosis to keep, as you rightly said, is congenital diaphragmatic hernia. Because of these loculations and these shadows, it's unlikely to be lobar emphysema, but you can still say, that this, since it is causing shift of mediastinum, another differential, which is unlikely that it can be lobar emphysema, but it is low on the list, something like that, high on the list, low on the list. And yes, even this one can be detected on antenatal ultrasound, then later on confirmed on MRI scan. And and little bit of description. It is hematomatous proliferation of terminal bronchioles with poor development of alveoli. 3 types are there: macrocystic, microcystic, and solid. Macrocystic are most common and they have better prognosis in comparison to the other types, and the cysts are more than 1 centimeter in size. Microcystic, the cysts are less than 1 centimeter. Solid has poor prognosis and is often associated with water abnormalities. Okay, can we start with candidate 4 now, please? Thank you very much, candidate 3. That was fantastic.
Thank you.
Candidate 4, can you raise your hand, please? Okay, would you like to start describing?
Yeah, I can hear you now.
Okay.
So I've got a frontal chest radiograph in a 3-month-old in which I can see that there is increased opacification of the left hemithorax, and looking at the right hemithorax, it appears like there's the right hemithorax is hyperlucent when compared to the left. So in a 3-month-old, I'm thinking I can see there's some mediastinal shift. I can trachea as well, but my differentials for a hyperlucent thorax in a 3-month-old, I'd include Swire-James in my differential. This could also represent, because I can see some lung tissue in the right lower lobe, this could represent a pneumothorax, which is causing a contralateral shift. It's too small to have a bullous emphysema. So these would be my 3 differentials.
Okay. Okay. And you feel it's small for emphysema?
Well, they could have emphysema as well, because they've got a wheeze and they could.
Which lobes are involved in lobar emphysema?
They usually like the lower lobes in congenital lobar emphysema. Can be in the left lower, but can vary.
Okay. So in this X-ray, we can see hyperlucency in right, middle, and lower zone, and shift of mediastinum to left side. So something is pushing the mediastinum to left side, isn't it? So,
Yeah.
and there is also added lucency. So based on that, and there is no internal septation or opacification in this, there is probably compression of the adjacent lung parenchyma as a result of whatever is going on. So yeah, that's how we have to consider. And so unlikely to be CPAM or diaphragmatic hernia in this case. So the pneumothorax should be...
The heavy diaphragm is quite distinct, and with CPAM, I'd expect a multicystic appearance.
Yes, yeah, that's true.
So
it's unlikely to be there. So two main differentials in this one should be lobar emphysema and pneumothorax, isn't it?
Yeah.
So you would proceed for cross-sectional imaging, or what would you do next?
So, because we've got a mediastinal shift in my day-to-day practice, I'd want to inform the pediatric team, because that needs to be addressed first before we move on to further imaging. With lobar emphysema, we could do a CT as well to better delineate.
Yeah, we will have to do CT if we have to confirm lobar emphysema, and without on ultrasound we can do ultrasound just if you are suspicious about CCAM or congenital diaphragmatic hernia. But if that is not on your differential list, then you would straight away proceed for CT. So CT, you can see that lobe is expanded and going on to the other side. So radiologically, we can see a hyperlucent lobe, progressive inflation of the pulmonary lobe, and compression of adjacent parenchyma, and contralateral mediastinal shift. The lobes which are involved in lobar emphysema are left upper lobe most commonly involved, then right middle lobe and right upper lobe. And the treatment is surgical, so they just remove the entire lobe. And these cases are also being picked up antenatally nowadays. And then we are aware, and they do MRI scan, and we are aware of the findings. So I've covered 3 important surgical conditions. They have overlapping features, and you have to just, be careful which one, or include maximum differentials as much as possible during the examination, and try to limit yourself first with the more clinical examination, history, ultrasound, non-ionizing radiation examination, and then move on to CT. So I've included some companion cases. So go on, candidate 4.
So I've got a supine radiograph in day not term infant. Can see the heart size is normal and the trachea is central. There is a difference in the transradiancy of both lungs. Mm-hmm. I can see lung markings on the right side, but not as well on the left. Mm-hmm. But there's no mediastinal shift. Sorry, I forgot to mention the NG tube is appropriately sited. That's the only line that I can see. Yeah. So we've got no mediastinal shift, and we've got a hyperlucent left lung. You can also see an opacity projected adjacent to the superior mediastinum on the left. Mm-hmm. But I think that's probably projectional.
You mean this opacity?
Yeah. So looking at this with no mediastinal shift and a hyperlucent left lung, thinking about an underlying Swire James, because I can't see any mediastinal shift to suggest that there's an emphysema or there's a pneumothorax, which is occupying the entire left hemithorax, and the diaphragms are quite distinct.
Okay, let me take over. And see, there is more lucency on right side, which is projecting up to here, isn't it? And there is an opacity here, which is left lobe of thymus. This is the right lobe of thymus. And why mediastinum is not shifted in this one? Because the pleura actually goes on to the other side and the air is only in the pleura. So this is a case of pneumothorax.
Okay.
Okay, so I've included it as a companion case. Just sometimes it can cause mediastinal shift also. So when you are describing those surgical conditions which we discussed just now, keep pneumothorax also in mind. That can be in one of the differentials.
Mani, maybe time to give a 5-minute break, please.
Yeah, after this one, and I'll just sum up with all the differentials of this topic. So yeah, after this one, we'll have a break.
Okay, so I've got a frontal radiograph in an acutely ill child. And I can see the clinical symptoms are reduced air entry on the left. And looking at the chest radiograph, I can see that almost the entire left hemithorax is opacified. I can't see any aerated lung except for the left apex.
Yeah.
Whereas when I look at the right hemithorax, it's a normal aerated lung. The trachea, I can see, so the entire left hemithorax being opacified, I can see is exerting a push on the trachea. So I don't take this to be a collapsed segment, a collapsed lung, because the trachea is being pushed to the contralateral side. So I'm thinking whether this is a large pleural effusion occupying the entire left hemithorax and causing contralateral shift to the right.
Yeah, absolutely correct. Why do you think it is so dense?
So it is quite dense compared to a normal effusion.
Yeah.
The other thing could be whether there's an underlying mass associated with it, which is...
It can be a mass, and what else there can be, and what will you do next?
So we could do we could obviously auscultate the lung, which will tell us as well, but then more than that, because we can't see any aerated lungs, auscultation would be of little help. We could do an ultrasound to see whether this is fluid or solid. And if it's fluid, then obviously we'll have to do a pleural tap.
Okay, see, it is quite dense, so that means it is a thick fluid, isn't it? What is thick fluid in?
So it could be a proteinaceous and exudative
empyema.
Empyema, yeah.
Empyema, yeah. So yeah, it is, as you said, that it is causing shift of mediastinum, and there is some mass effect. And underlying mass has to be suspected, and we would start with. Since the child is acutely ill child, so we are not so much worried about the mass at this stage, and we would proceed for ultrasound scan. And what do we see on ultrasound scan in a case of empyema?
So an empyema, I've seen a simple effusion on an ultrasound, but I guess it would be much thicker, more dense appearing on ultrasound.
Yeah. It is loculated collection. So that's what usually clinicians ask us to look for. So most of these effusions, they would refer for ultrasound scan, and they would ask us to look for any loculations. So if loculations are there and the patient is not responding to treatment, then probably an intercostal drainage tube and streptokinase treatment is needed. So they have to, refer to the tertiary referral center and start the management actively. Okay, and the other possibility is obviously a mass. If the patient does not respond to the treatment, this opacification does not resolve, then they have to consider the other differentials. So I showed you these two cases because they also cause shift of mediastinum, and you have to keep in mind that the shift of mediastinum can be caused by two non-surgical conditions also. Okay, so we'll discuss the differential diagnosis after we come back from break. We'll have a short break of 5 minutes, and we'll start, remain with me, candidate 4. We'll start with you.
Thank you.
neonatal respiratory distress. And so neonatal respiratory distress without any mediastinal shift. 3 conditions we have to think about: hyaline membrane disease, transient tachypnea of newborn, and meconium aspiration syndrome. They have already been discussed. So in hyaline membrane disease, the infant is preterm, the lungs are small, they can be reticulogranular pattern, obscured outlines, and the complications can be PIE, pneumothorax, pneumomediastinum, and chronic lung disease. In transient tachypnea of newborn, the lungs are normal or hyperinflated. They can show prominent markings, thickened septae or fissures. In meconium aspiration, there will be coarse lung markings with areas of inflation and atelectasis. There is possibility of pneumothorax and effusions also. So just comparing hyaline membrane disease with transient tachypnea of newborn, these are hypoinflated lungs and these are slightly hyperinflated lungs. They can be haziness and they can be here, it can be streaky opacities or thickening of the fissures. Small pleural effusions can also be there. And these are the other conditions we have discussed. So they can be PIE, also without any mediastinal shift, chronic lung disease, and meconium aspiration. So they all show coarse opacification or coarse pattern of the lung. So these 3 differentials you have to think about when you see such a coarse pattern in the lung without any mediastinal shift. So neonatal respiratory distress left side with paucity of gas in abdomen, ring lucencies, etc., and congenital lobar overinflation, and the lobes involved are left upper lobe, right middle lobe, and then CT is used for confirmation. Congenital pulmonary airway malformation, these are predominantly seen in the lower lobes. Pneumothorax and pleural effusion also you have to keep in mind. Shift towards abnormal side will be atelectasis, agenesis or aplasia, or hypoplasia of the lung. So when you are looking at agenesis, look for other signs of any abnormality, hemivertebrae. Also look at the pulmonary vasculature because hypoplasia can be associated with congenital cardiac diseases also. So we are moving on to the next case. Candidate 4, are you with me?
Yes.
Yeah.
So I've got a frontal chest radiograph in a 5-month-old presenting with repeated left lower lobe infections, and I can see that there's a retrocardiac opacity in the left hemithorax, just above the medial diaphragm on the left. The rest of the lungs are clear, can't see any pneumothoraces. So a child presenting with repeated left lower lobe infections, I'd like to exclude an underlying pulmonary sequestration. Mm-hmm. Which has 2 types, intra and extra, but in a child, I'd be suspecting extralobar sequestration. We can assess these with a CT or an MRI because we have to make sure we see the draining vein and the artery because they tend to have an abnormal, they have systemic arterial supply, but the drainages can be pulmonary in an intra and extra pulmonary in an extra. Yeah. So
yeah, wonderful. Yeah, that was fantastic. Yeah, you have told all the findings. Yeah, I didn't leave any questions for me. So there is opacification there is a retrocardiac opacity with obscure diaphragmatic outline, and with repeated lung infection, you have to consider sequestrated lung. So what is sequestration? Sequestration is a part of the lung which has which has systemic supply. So rather than the pulmonary artery being supplying that part of the lung, aorta directly supplies sequestrated lung. It can be intralobar and extralobar. Intralobar is more frequently seen. Extralobar is less frequent, but is usually detected early because it is associated with other congenital anomalies. And intralobar usually presents as pneumonia. And majority of them are seen in the lower lobe, more commonly on left side. So how do we confirm that? As you said, that CT is the answer, and we can do a CT angiogram, or we can also detect with the help of MRI scan. And yes, so this is intralobar diagrammatic view of intralobar sequestration. So intralobar does not have its own pleura, whereas extralobar has its own pleura, a systemic supply, and the drainage is by azygous or hemiazygous vein. Here the drainage is by the pulmonary veins only. So that's what you see on CT, that there is consolidation of the lower lobe. And that's what you see on an angiogram, that there is a systemic supply to a part of the lung. And that you can detect even on fetal MR. You can see a vascular vessel going into the lung. And sometimes there is an overlap of these abnormalities. They usually, sequestration can be associated with CCAM, which was probably happening in this case because this lobe is quite expanded. So sequestration can be associated with CCAM in some cases. Okay, can we start with candidate 5 now? Thank you very much, candidate 4.
You're welcome.
Yes, can you hear me, candidate 5?
Yeah, I can hear you.
Yes, please, go on.
It's a frontal chest radiograph of a unit. Probably, I think, premature, which is demonstrating opacification of right upper and middle zone. The left-sided lung is normal, so is the right is the lower zone and apex. I cannot see any other abnormality. So findings are. I can see. I think probably the projecting not that clear, but I think there is some air bronchogram through the right middle lobe opacity. If that's the case, then the findings are consistent with pneumonia of the right side. Especially, I would consult the pediatric team to find out if the patient is unwell or septic or if there's an infected picture.
The patient did present with some upper respiratory tract infection symptoms, and that's why they did X-ray. Yeah, so just to sum up the findings, that mediastinum is normal, okay, and there is some opacification in right upper and middle zone, which has a very sharp outline at the bottom, and left lung is absolutely clear, right lower zone is absolutely clear. Okay, I'm just going to describe this one, come back to it. Let's discuss the other case. Would you like to describe this for me, please?
Yeah, it's a frontal chest radiograph of a 6-year-old child, which is demonstrating it's an AP erect film, which is demonstrating an air fluid level and the opacification of the right upper and mid zone. Mm-hmm. The rest of the lung appears normal. There's some maybe atelectasis in the right lower zone, but the main finding is in the right upper zone and the middle zone with the air fluid level signifying there is a air-filled cavity. If a patient is unwell, this could represent a lung abscess. I'll need to correlate with clinically with the team.
Okay. Okay, patient was quite ill. See, if you see that he's just restricting his right side, the actually the volume of right side is less, and he's tilting to right side, which is which suggests that patient is probably pleuritic on right side. So yeah, as you said, there is opacification of right upper zone, and probably opacification here also, which is right middle lobe area.
Yeah.
The diaphragm is seen, and there is some haziness just above the diaphragm, which can be due to small amount of pleural effusion. Otherwise, the cardiac shadow looks normal. See, there is little bit of scoliosis also.
Yeah.
Which occurs in cases when there are infection, because they just try not to expand that side, and they tilt to that side so that it doesn't cause pain. So this is a very commonly seen finding, that there is right upper lobe and right middle lobe consolidation in this one, probably associated with some pleural effusion. Now let's go back to the first one. Now, do you see any difference, or would you like to change your mind?
There's no scoliosis, first of all.
Yeah.
The volume isn't preserved, or maybe enlarged or preserved, maybe. Because the intercostal distance is fine.
Yeah.
And there's a sharp margin to this opacity.
Okay. Okay. Can I interrupt you? You see the density. Because I want to make this very clear that this is not dense, isn't it? In comparison to this one, that is quite dense. So that means there is, and also at the periphery, you see that there is probably, it's undulating margins. What does that mean? And there is nothing in the apex. Apex is fine. So it can be confusing. This is actually an enlarged thymus. Okay. So what do you do when you are confused? You are not sure that it is thymus or it is consolidation. Or thymus should be considered in young children. It can have very vague appearance. So what do you do? How do you confirm that?
You can do lateral to characterize which mediastinal structure it is, or you can do an ultrasound scan as well.
What do you see on ultrasound scan?
On ultrasound, if it's thymus, you will see the thymus tissue. But I think lateral will be helpful here to characterize which mediastinal compartment this opacification is.
Yeah, let's take it further. Thank you very much. And this one, would you like to describe this one also before I sum up all the findings?
So it's a frontal chest radiograph of a neonate, which is demonstrating a large opacification centered over the right hemithorax, sparing right costophrenic lung. There is some. This opacification is kind of not very dense. Heart border is obscure, but I can still see the bit of sharp margin of the heart, which is denser than this opacification. So there is some sort of similarity maintained, but so in summary, this opacification is in the right upper and mid zone. This could be infection.
Yeah.
The other differential here would be a mediastinal mass.
Okay.
Because the border is very smooth if you look at the lung. So it's a very sharp border.
Yes.
Right?
Yeah, so, that's correct. What does it point? Sharp border.
Sharp border, it could be lobar kind of pathology, or it could be a solid mass.
This is a neonate presenting with some grunting and some respiratory distress. Actually, he presented with tachypnea, and that's why the X-ray was done. That's just tachypnea, no sepsis at all. Anyway, I'll just take over. Sorry for just because the time is short and I want to complete this. So we did ultrasound scan, as we discussed in the previous one, that if there is a mediastinal pathology, actually ultrasound is very useful, and we really don't need to use the CT in the first instance, because if ultrasound is able to answer our query, then why not use it? It's much quicker, doesn't need sedation, and we see a very homogeneous area here, just around the cardiac shadow, just abutting, very well circumscribed. So it is a thymus. Okay, so thymus can have very different appearance in different individuals, and it can cause a lot of confusion if you're not reporting these pediatric radiographs regularly. The clue is that this is not dense. I'm so sorry. That look at the margin, that it is well demarcated, which points that is benign abnormality or benign condition you are dealing with. And then there is lucency also, which is again very important. There is no expansion of the thorax at all. Okay, so these are the points which you should consider, that density of the lesion, outline, and homogeneity. Density, homogeneity, and outline. And then if you are still confused, you can ask for ultrasound scan. These are, real life scenarios when we just find it difficult to say that, oh, it is definitely thymus. And then we move on to ultrasound. And on ultrasound, we see starry sky appearance, that there is speckled brightness amongst the homogeneity. There is speckled brightness. So that's why it is called starry sky appearance. So this is another appearance of thymus when it is on both sides. Okay, so there is no shift of mediastinum or trachea, and this is slightly loosened, and there is no expansion of the rib cage in this region. So again, ultrasound was done in this one also, and we see both the lobes enlarged. Yeah, I'm going to take thymus separately also. Yeah, let's move on to the next one.
So it's a frontal chest radiograph of a 7-year-old child with upper respiratory infection, which is demonstrating an opacity in the right medial mid and lower zone, especially in the right cardiophrenic angle. Mm-hmm. It's quite smooth margined and sharp. Yeah. The density is again, it's not very dense. Mm-hmm. There's no lung volume loss, and rest of the lung, I think it's overexposed on both sides.
Yes.
So appearances are quite suggestive of a mediastinal mass.
Yeah.
The location is quite typical for cardio. What do you call it? The cyst, bronchogenic, cardiogenic cyst.
Okay. Any other differential? And what do we do next?
A foregut duplication cyst can present. A few of the cysts can present like that in this age group. Mm-hmm. Other differential could be thymoma. I don't think thymoma is going to be presenting like that. Mm-hmm. Ectopic tissue or ectopic thyroid here, which is again unlikely. Lymphoma can present like that, although there's no increased lobulated lesion on the other side, contralateral side, on the left side.
Yes.
But lymphoma still should be considered.
Yeah, what will you do next?
So patient would need a cross-sectional imaging, or at least to begin with lateral chest X-ray. If not, then CT chest to further characterized.
Yeah. So there is a lesion which seems to be averting. There is a mediastinal pathology which seems to be averting the cardiac silhouette, so anterior or middle mediastinum, and it has a well demarcated outline. And the next investigation in this age group, ultrasound is less likely to be useful, so you would straight away move on to CT scan. Okay, for better evaluation, because you just can't leave it like that. And if it was a thymic abnormality, it should have been more in the superior mediastinum rather than this part. And moreover, at this age, you don't expect to find enlarged thymus unless there is a problem, there is a mass or anything. Okay, so CT scan, and that's what you find, that there is a mass with some lucent area. So what's your diagnosis?
So there are some lucent areas. I can't see any calcification.
Probably, yeah, there is some.
Okay. So teratoma would be.
Yes.
Yeah.
So this was indeed a teratoma. And the next one.
It's this 11-year-old child having a frontal chest X-ray history of choking, which is demonstrating superior mediastinal mass. Cervical thoracic sign is there on the right side, and on the contralateral side there may be a bit of again opacity. So appearances are suggestive of some superior mediastinal pathology. The top differential could be enlarged thyroid or retrosternal thyroid causing this tracheal compression and choking. I would consider first of all ultrasound scan, but obviously ultrasound wouldn't cover the retrosternal area. But I would begin with ultrasound scan. The patient may need a CT scan as well.
Okay. See, on X-ray, there is no shift of mediastinum. Okay. The trachea is absolutely central, and there is a lesion which shows a very well circumscribed outline. Okay. Looks like a cyst.
Okay.
Okay. So what it can be?
It can be duplication, a foregut duplication cyst category. So it could be esophageal.
Yeah.
Yeah.
So we'll move on to the next examination, because obviously X-rays will be quite limited in what information we can get, and the best examination would be CT scan or MRI scan. So yeah, there is a cyst. It's a bronchogenic cyst. Does not cause any significant mass effect as such. It can cause mass effect, but it may not cause. It may just be silent for years together. So bronchogenic cysts, they can be mediastinal. Mediastinal will be paratracheal, carinal, or hilar. They can also be intrapulmonary. They are usually round and sharply marginated and are seen within medial third of the lung. They do not communicate with tracheobronchial tree unless they are infected or there is any instrumentation. They may present with obstructive overinflation of the lungs by ball valve mechanism, and they are usually filled with serous or mucoid fluid. They can be solitary, and they are usually solitary and unilocular, and normally there is no wall enhancement unless they are infected, and usually they are incidental finding. Unless they cause obstruction, they are usually not detected, and they are left alone also. They are not removed unless they start causing any symptoms to the patient or are extremely large. Okay.
It's a frontal chest radiograph in a young patient with a history of wheezing. There is a hazy opacification, diffuse homogeneous opacification of the right upper zone, as well as almost whole left hemithorax. Apart from that, I think, I don't know whether it's rotational, but left lung volume appears reduced, although there is no crowding of ribs on the left side.
Yeah.
The hilar's positions are maintained, so is the trachea, which is central. There's no pleurofusion, and there's no retrocardiac mass. So in summary, there is a homogeneous opacification of the right upper zone and the left hemithorax.
Okay, I'll sum up the findings for you. See, there is the mediastinum appears to be slightly shifted to left side, and it can be difficult, because the projection might be different. So for you to understand, since I know the patient, I know the disease also, there is some lucency. There is some lucency in this one, in this area, in right middle zone and right lower zone. And there is some haziness. It's probably projectional haziness on left
Are we
side.
talking about allergic bronchopulmonary aspergillosis ABPA with finger and glove projections on the right lower
So
zone?
there is some lucency in right middle and lower zone, and patient is presenting with history of these. So keeping these together, anything comes to your mind?
Experiencing allergic enteritis, they do have history of these or asthma. Scherk-Strauss vasculitis, a form of vasculitis can cause.
And anything else? Okay, not to worry. So there is abnormal lucency in right middle and lower zone, and there is slight shift of mediastinum. So patient was about 2-3-year-old, and so this kind of finding you would see in a foreign body. And how do you confirm a foreign body that there is lucency, and what would you do next in a case of foreign body?
To confirm the foreign body?
Yeah, to confirm foreign body and to confirm the findings that there is probably a foreign body, because you may not see the foreign body.
CT?
Okay, so when you see such finding with that kind of history, you like to ask, obviously, history, that is there a chance of foreign body, but you may not get the foreign body history, but the suspicion should be very high, and you try to take expiratory views. And if that is not possible because of the age of the child, we can do fluoroscopy also, and the movement will be less. And on expiratory views, if we did acquire, there will be more expansion of the abnormal area. So on inspiration, there is more air trapping, which will cause the lung to expand further in expiratory views. And if the child is not able to cooperate for expiratory view because of the age, then we can do a fluoroscopic examination also. So bronchial foreign body, yeah, these should be considered as a differential when you see abnormal lucency in slightly grown up or 2-3-year-old child. So bronchial foreign bodies can be anything. They can be radiopaque or radiolucent, but more likely radiolucent. Peanuts are very dangerous. So 55% are right-sided because of the angle, straight angulation of the bronchus. They just land up in the right main bronchus. And they can be left-sided or bilateral also. And only 5 to 10% are radiopaque. So radiologically, what do we see is reduced movements, which can be checked on fluoroscopy, hyperinflation of that part of the lung, and expiratory radiographs are therefore very useful. And also we can try doing decubitus view in very young children with suspected side up. Okay, so that is likely to expand further when we do decubitus view. Collapse occurs due to long-standing foreign body. So they have to be referred and the foreign body has to be taken out immediately. So some miscellaneous cases now. Can we move on to candidate 6 now? Thank you very much, candidate 5. Are you there, candidate 6? Hello, candidate 6. Please raise your hand.
Mani, let's go to candidate 7. Maybe there is something wrong.
Okay. Oh, candidate 6 is there.
Okay, I will unmute now candidate 6. Candidate 6, can you hear us?
Hello. Would you like to start describing?
Sure. So I'm presented with a chest radiograph of a pediatric patient with 3-month history of weight loss. First thing to note here is there is some patchy opacification in the left upper to mid zone. There's obscuration of the left heart border.
Yeah.
And looking at the bone specifically, I can see there's possible resorptions of the left lateral clavicles and also some destruction, what appear to be some destructions of the left humerus, especially the humerus head and also the epiphysis. Given the history of weight loss, I'm thinking of more a sinister underlying condition. And given the opacification that I see and bony destructions, my first thought is, could this be a posterior mediastinal contour loss?
This is projectional, so there is nothing wrong with the bones. This is just appearing loosened because of the projection. So describe the lung findings, please, for me.
Sure. The lung finding is patchy opacifications, left upper mid zone, loss of left heart border. First thought is, could it be infection, like a pneumonia? But with a history of weight loss, I'm thinking malignancy, but I can't think of anything pertaining to the lung that would give this appearance. The thymic contour is normal.
Yeah, it's this one is a slightly grown-up child, isn't it? Look at the humeral epiphysis, maybe 10, 11-year-old. So you wouldn't expect thymus to be seen at this age. But having said that, let's go on some of the findings. So there is some opacification in left upper and middle zone, and which is silhouetting the cardiac border. And there seems to be some widening of superior mediastinum also. So which, considering the age of the patient, maybe 10, 11, it's more likely to be, suspected lymph node enlargement.
Yes.
Okay. So lymph node enlargement in mediastinum, and there is opacification in the lung, so which is probably a consolidation because there is clear silhouette of the cardiac border. And with this kind of history, what would you like to consider and what would you like to do next?
Sure. Given a superior mediastinal mass, as we think it could be lymphoma. So further investigations, I will skip the step of ultrasound for this patient by proceeding to cross-sectional imaging.
Yes.
With the CT.
Okay. Any other differentials?
So it's likely an anterior mediastinal mass. So apart from lymphoma, could be thymoma, teratoma.
Okay. Okay, so this is the diagnosis of this one. So right paratracheal and hilar lymph node enlargement, although hilar lymph nodes we don't see very well on this X-ray, and it would be better demonstrated on a CT scan, and there is consolidation. So even TB is a part of the differentials and should be considered. So TB also can be seen in children as well. Okay. So in TB, what happens? I'm just going to describe that this is the initial infection, primary complex, which is called Ghon's focus, and this is the initial pneumonic reaction to the infection. So this will be mostly in the upper lobes. And then Ranke's complex is combination of the initial inflammatory focus in the lung and the lymphatic spread to the regional lymph nodes. So in this case, it's the Ranke's complex, that lymph nodes are also enlarged. But you are absolutely right in saying that you would suspect a sinister pathology and you would suspect lymphoma, but include TB also in your differential list.
Sure.
Yeah. Okay, next one. These are all miscellaneous conditions, so you would see a variety.
Sure. So I'm presented with a lateral cervical spine radiograph of a 5-year-old child with a history of dysphagia. So the straightening of the cervical spine and looking at the pre-vertebral space, specifically at the upper cervical region. There's widening of the of the region, and also I can see there's impressions of a rounded, well-defined opacity just anterior to at the level of C2.
Mm-hmm. Yeah.
So with the history of dysphagia, I'm thinking whether could there be an external compressions of the upper digestive tract in this child by this well-defined mass. My differential here is, could it be a tonsillar mass or abscess?
Mm-hmm. Yeah. Anything else in the differential?
It is not in the typical locations of the parotid gland.
Yes, it is. Yeah, you're right.
And
what would you do next?
If a barium swallow could potentially help to see whether this mass lesion is extrinsic or is it intraluminal within the esophagus.
Okay. What do you think about the thickness of this space? Space? How much it should be and how much is it thickened?
It is widened, especially in the upper cervical spine.
Yeah.
And it should be, I think, less than 5 millimeter. Is that right? Yeah,
so it should be less than, it's definitely more, isn't it? It's more than one vertebral body, which is the correct correct dimension for the lower part. So it is definitely, there is definite widening. And to get the correct answer, what's happening, whether it's intraluminal or extraluminal, and especially patient presenting with dysphagia, we might go on for cross-sectional imaging, CT or MRI scan, whatever is available. MRIs with contrast is definitely better, but in younger children, there is a limitation that they need to be sedated. And with this kind of, problem, nobody would like to intubate the child, isn't it? So we would probably go on for CT in such scenario. So as you said, there is widening of the retropharyngeal space or the prevertebral space. So the differential diagnosis would include all retropharyngeal soft tissue thickening ones or, okay?
Sure.
So these are the differential diagnoses which should be considered. Obviously, the acute epiglottitis will not fit and laryngobronchitis in this one. So the main differentials to consider in that case would be retropharyngeal abscess or a foreign body or retropharyngeal hematoma due to trauma or surgery. And the next test is a CT scan and probably with contrast. Okay. So we'll move on to congenital heart diseases. And I'm going to briefly touch this area because not too much is being asked as yet. And so I'm just going to briefly touch this area so that you are clever enough to say, that what it is a heart disease or not. And we don't do echocardiogram. Obviously, it has to be complemented with echocardiogram also when we are considering congenital heart disease. So based on radiology, what we should look for, I'm just going to touch this area. So incidence analysis, and if we do a sequential analysis, we are unlikely to miss the findings. So in this one, first we assess what is the situs of, situs means where is the apex, the cardiac positioning is normal or not. Apex is usually on left side. It is on left side actually. Liver on right side, spleen on left side, stomach on left side, and the bronchus is left main bronchus is longer. So situs can be soletus, inversus, or ambiguous. Most of the time it is soletus. And then we assess the aorta, how the aorta looks. Is it enlarged or it is smaller, on which side it is, right-sided or left-sided. Is there any abnormality in shape of aorta? And then we move on to the pulmonary artery, main pulmonary artery first, and then rest of the pulmonary vasculature. And later on, the chamber enlargement. Is there any significant chamber enlargement? Like right atrium would enlarge on right side. A left atrium would cause a retrocardiac shadow. And left ventricle would enlarge on left side, dipping the dip of the apex. And if right ventricle is enlarged, the apex would be slightly upturned. And also in most of the enlargement, the cardiac size will be increased. And last but not the least, we have to have a glance at the spinal column, rib cage, and the sternum. So these 5 points, if you go through, you would be able to describe a cardiac condition and narrow down the differential, and then if needed, refer for echocardiogram. So yeah, let's start with our differentials first. So in the common acyanotic lesion, so you can ask this question, is it a cyanotic condition or an acyanotic condition? Most of the cyanotic lesions would present early in life. So they are unlikely to be seen later in life, like a child presenting at the age of 2 years or 5 years. It's unlikely that you would come across a cyanotic condition. So the acyanotic conditions which you should consider are ventricular septal defect, atrial septal defect, PDA, coarctation of aorta, mitral stenosis, and incompetence. These are relatively not so important, so unlikely to be asked in the examination. Common cyanotic conditions, they present with decreased flow and also can present with increased flow. So the presenting with decreased flow or pulmonary oligemia are tetralogy of Fallot's, tricuspid atresia, and Epstein anomaly. And with increased flow, it is transposition of great vessels, truncus arteriosus, single ventricle, total anomalous pulmonary venous return with infradiaphragmatic obstruction, and DORB. So these are more important from exam point of view, and the other ones which I showed you, these ones. So if you know the appearances of these ones, you should be okay. So let's start with our first case.
Sure. So this is a chest radiograph of a pediatric.
And since these are cardiac cases, if you do the sequential analysis, just like we discussed, starting with the apex, that would be great.
So I'm starting to look at the cardiac silhouette. So the apex is elevated, and the size and location of aorta is central. Pulmonary artery and the vasculature, they are decreased. There's this decreased pulmonary vasculature, and there is increased chamber enlargement. There's no predominance. It's general increased cardiac silhouette.
Yeah, wonderful.
And then last, reviewing the spine, rib cage, and sternum, there is no gross abnormality. Okay. So in summary, I think this is a boot-shaped heart in tetralogy of Fallot.
Wonderful. Okay, so let me sum up the finding and then I'll ask other questions. So in this case, the apex is slightly upturned, like it is not dipping down at all, and it appears slightly upturned. And then the cardiac size is not enlarged. And then moving on to aorta, aortic knuckle is seen on this side, on right side. So aorta is on right side. And if we look at the main pulmonary artery, it is not seen. It is causing a sort of pulmonary bay. This is the pulmonary bay. And then we go on to the pulmonary vasculature. It appears to be reduced. It's hardly seen. You don't see the main pulmonary artery at all. And also the rest of the vasculature is quite thin. And there is no chamber enlargement as such. and then spine and rib cage is normal. And as you said, the diagnosis is tetralogy of Fallot. What are the components of tetralogy of Fallot? What's happening in this case?
So we have pulmonary stenosis, right ventricular enlargement, BSD, and overriding aorta.
Yeah. So, and they usually present early in the age, and the typical history is cyanosis on crime. So this is one of the cyanotic condition presenting with oligemic lung fields. Okay. So the components, as you already described, are infundibular stenosis, overriding of aorta, right ventricular hypertrophy, and BSD. Radiological features are right-sided aortic arch can be seen in 25% cases. The heart is normal size. There are oligemic lung fields. Pulmonary bay or concavity is seen, and boot-shaped sign is produced by upturning of the cardiac apex because of right ventricular hypertrophy and by concavity of the main pulmonary artery. And surgery is done in such cases, which is Blalock's thoracic shunt, and it involves anastomosis of the right subclavian artery to the pulmonary artery. Okay, candidate, can we move to candidate 7 now, please? Thank you very much, candidate 6.
Thank you.
Are you able to hear me, candidate 7?
Yes, I can hear you.
Yes. Would you like to describe it for me?
So it's a 1-year-old child with a murmur. So in terms of situs, there is levocardia. I can't really see the gastric bubble. The aortic arch is left-sided.
Wonderful.
And then the pulmonary artery is visible, probably slightly enlarged, I would say, on the right.
That's correct.
Cardiac chamber enlargement, there is cross cardiomegaly. I'm not sure if there's any particular predilection for right versus left. Looking at the spine, the rib and sternum, they look unremarkable. So in summary, we've got I think diffuse gross cardiomegaly affecting all chambers with an enlarged pulmonary artery and increased vascularity with a left-sided aortic arch. Would I be able to ask if this is, I assume with the 1-year-old child, this is probably an acyanotic heart disease.
You are absolutely right. That's how you have to, just judge that probably, and it is acyanotic.
So this would probably be most in keeping with a VSD.
Wonderful, wonderful description. And yeah, it is VSD indeed. So VSD, what happens in VSD? There is a shunt in the ventricles. So there is cardiac enlargement and there is biventricular hypertrophy. And that's why you don't see any, if you see carefully, there is slight dipping of the apex. Slight dipping of the apex would be there, but you may not appreciate it in all the cases. And obviously the pulmonary artery is quite enlarged and there is plethora as well. So that's what you see as the findings. And VSD presents much earlier than ASD. All right.
So again, a 5-year-old child with a murmur. So looking at the situs, so levocardia. The aortic arch is also left-sided. The pulmonary arteries are, again, enlarged bilaterally. In terms of pulmonary vascularity, I'd say it's also peripheral pulmonary vascularity is also increased. There is cardiomegaly, but only mild. The apex is appropriate. It's it's not upturned or dipping, so it looks appropriate. The right-sided, the right heart border, maybe there could be subtle right atrial enlargement. It has a slightly more convex contour, I would say. Looking at the spine, ribs, and sternum, I can't see any other abnormalities. So a slightly older child with mild cardiomegaly and shunt vascularity. I think this is probably, given the age, probably an ASD rather than a VSD or a PDA. I can't see any other rib notching or anything else that would make me think of.
Fantastic. And let me sum up the findings now. So there is the cardiac size is not significantly enlarged or not enlarged, and the apex is left-sided, so situs soletus. Aorta is on left side, and there is some straightening of the cardiac border. I'll come back to this, and there is increased pulmonary vascularity and unremarkable bony cage and all. So in ASD, what happens is there is slight rotation of the heart on its axis, and that's why we see the straightening of the left cardiac border. It can easily be confused with mitral stenosis or mitral regurg, but then if you see the retrocardiac, there is no enlargement of LA. Okay, there is no enlargement of LA. What does LA cause? One is it causes double cardiac shadow. Secondly, it causes expansion of the carina, that there is widening of the carina. So it is not there. So in absence of that, it is not mitral stenosis. Okay. So that can be the differential in this, because there is straightening of the cardiac border. So straightening is because of slight rotation of the heart on its axis, which happens in ASD. But yeah, wonderful description. So ASD, mild cardiomegaly with slight rotation of the heart to left. There is pulmonary plethora and LA is not enlarged. Next one.
So frontal radiograph, this seems like a slightly older child. In terms of situs, levocardia, the aorta is left-sided. The a contour of the left mediastinum is also abnormal. It has a sort of a three-shaped configuration. The pulmonary arteries are within normal limits. The hearts, there's no cardiomegaly. Looking at the ribs, there's bilateral inferior rib notching.
Spot on, yeah.
And it's, I think it spares the second rib. So this would be in keeping with coarctation of the aorta.
And how do these children present?
I think it would be a bit too early to present with hypertension. They could present with an ejection systolic murmur. Yeah, I'm not sure of any other symptoms.
Yeah, they usually present with hypertension. So let me sum up the findings for others. There is the situs is soletus, the apex is on left side. Then we can see the aorta on left side, and also it appears to be shape of reverse 3 sign or 3 sign. And then there is notching of the ribs, and there is no particular chamber enlargement. The pulmonary vascularity is within normal limits. So usually these children, they present with hypertension, or it can be systolic murmur also, but they present with headaches and hypertension. So, yeah. Aortic coarctation, rib notching is caused by pressure from the intercostal blood vessels, and reverse figure of 3 sign is formed by pre-stenotic and post-stenotic dilatation of aorta with an intervening indentation at the site of coarctation. And the confirmation is usually by MRI scan these days. no need to give radiation. Okay, next one.
So AP supine portable of a fairly young baby. So in terms of situs, it is levocardia, gastric bubbles on the left, liver is on the right. So in keeping with situs solitus,
Yes.
aorta is left-sided. Pulmonary arteries are difficult to visualize, but there is oligemia, reduced pulmonary vascularity in the visualized lung.
Wonderful.
There is massive cardiomegaly, which almost takes up the takes up the entire thorax. The spine, ribs, and sternum, no other abnormalities. So, in summary, this I think I can see an endotracheal tube I should have mentioned, or which is appropriately cited. So, in summary, this is massive cardiomegaly with reduced pulmonary vascularity, which would be most in keeping with Epstein anomaly of the heart.
Incredible. Yes, wonderful. So yeah, the situs is solitus and the apex is on left side. The aorta is on left side, normal side. Pulmonary arteries are not seen. That means, and it's no pulmonary vascularity is seen. We can see a little bit here. It is in keeping with pulmonary oligemia. And there is cardiomegaly with chamber enlargement predominantly to the right side. So in Epstein anomaly, there is right atrial enlargement. And there is no obvious abnormality in the rib cage or the spinal column. So this is indeed an Epstein anomaly. This is a cyanotic cardiac condition. And children present early on.
So, a frontal chest radiograph, again, a fairly young patient. Sorry, is the projection, is the image?
Can be a problem. Yeah, there is a problem with
the I can't see that well. But anyway, I'll do what I can. So, in terms of, left-sided aortic arch, left-sided gastric bubbles, so situs solitus. I did speak about, sorry. Levocardia, aortic arches on the left side. Pulmonary arteries, from my projector, I think it looks normal. I can't really comment on the vascularity on my screen. It's suddenly become really...
It is increased vascularity slightly.
Oh, okay, fine. So increased pulmonary vascularity. Heart size, I'd say, is probably within normal limits.
Yes, yeah.
Looking at the spine, ribs, and sternum, I can't see any gross abnormality. So, in summary, normal heart size with a left-sided aortic arch, but increased pulmonary vascularity. I'm thinking of may I ask if this is this a cyanotic or acyanotic child?
That is a very important question, and you have just asked at the correct moment. Yeah, it is a cyanotic heart condition.
Cyanotic heart condition. So it's got cyanosis with increased vascularity. So I think there could be a number of causes. It could be transposition of great arteries.
Yes, yeah. That is the one. And see the narrow particle here. I know it's very difficult to come to a conclusion, but the way to describe is, and to reach the conclusion and to reach the differential diagnosis, that's what we want, and rest we leave to echocardiogram. So yeah, the cardiac size is not enlarged, and there is pulmonary plethora, and you are absolutely fine to ask if it is a cyanotic or acyanotic condition. And with this narrow pedicle here, it is TGA. But you may not reach the conclusion, that's absolutely fine. Okay.
looks a chest radiograph of a slightly older child, levocardia with gastric bubble on the left, in keeping with situs solitus. The aorta, I think it's it's a right-sided aortic arch. Pulmonary arteries are normal. In terms of their heart size, it's pretty mild cardiomegaly with elevation of the cardiac apex. Pulmonary vascularity, summary, increased pulmonary vascularity with probably right ventricular hypertrophy. And I can ask, is this in a cyanotic or acyanotic child? I think it's older patients. It's probably acyanotic, but
it's cyanotic.
Cyanotic.
Mm-hmm.
So cyanotic heart with increased pulmonary vascularity, and I think also a right-sided aortic arch. So I'm thinking of truncus arteriosus.
Okay, so we'll discuss in the end. Let me go through, because the cases are jumbled up, and then we'll go through the diagnosis again, later on. Okay, so okay. I'll just keep on discussing, and then let you know the diagnosis in the end.
Okay, so there is an inhaled foreign body. It has the appearance of a coin. Lung volumes are equal, no air trapping or atelectasis. Oh, do you want me to say all the other bits?
Yeah, where is the foreign body?
Oh, sorry, the foreign body is oriented in the coronal plane, so it's in the esophagus.
Okay. Okay, yeah.
Oh, no, sorry, trachea. Sorry, this is in the trachea.
Okay. Okay, we'll discuss in the end. Let me go through all the cases and we'll discuss it.
So, looking at the lines, there's an endotracheal tube in situ. There's also a nasogastric tube. It's difficult to see where the tip is, but it's below the diaphragm. The UAC is appropriately sited at the level of T9. The UVC is low. The tip is probably at T6 and should be it's probably in the right atrium and should be pulled lower down. There is also the impression of a right pneumothorax. There is also increased opacification of the left lung with some tracheal deviation to the left. There's also some compressive atelectasis of the right lung. Looking at the bowel gas pattern is unremarkable.
Mm-hmm.
So in summary, there is a UVC which is misplaced. There is a right pneumothorax with mediastinal deviation to the left. I'd inform the pediatric team.
Wonderful. Okay. Shall we start with candidate 1 now again? Thank you very much, candidate 7. We'll start with candidate 1 again.
Yes, please. Candidate 1, are you with us?
Yes, hi.
Yeah, hi. Okay, this case is for you.
Okay, so frontal radiograph of the chest and abdomen in a neonate. There's increased lucencies in both lungs, the right thymus appears normal, but the left thymus appears slightly elevated, and I'll be concerned about the cell sign appearance in keeping with the left-sided pneumothorax.
Yeah.
Okay, so this is a frontal radiograph of an older child. The right paratracheal stripe appears to is expanded, and there's bilateral symmetrical hilar adenopathy. There's also increased lung markings bilaterally, which appears to be symmetrical. Given its appearance, my differentials to consider would include sarcoid and TB.
What will you do next?
So to correlate with the clinical history, if there's any history of recent travel, I'd also correlate with the patient's blood markers. If the ACE is elevated, that may be more in keeping with sarcoid, and recommend referral to the chest physicians and acid fast bacilli staining if there's concern for TB.
And any investigation, radiological investigation you would like to consider with this kind of appearance?
So the patient may need cross-sectional imaging, although they're a child. So depending on the symptoms, if they have symptoms of TB with night sweats and or weight loss, then I recommend a CT confirm. Okay, so I presume this is a CT of the same patient?
Yes, it is.
Okay, so there's cavitation in the right apex with tree and bud nodularity, as well as bilateral hilar adenopathy. The left lung appears to be clear. There's no pleural or pericardial effusions. There's no abnormality in the imaged bones. So findings will be most concerning for primary TB.
Yep. Same patient.
So this is the mediastinal window in sagittal, axial, and coronal planes with an arterialized study. And I can see low attenuation lymph nodes predominantly in the right surrounding the main pulmonary artery, as well as some enlarged right paratracheal lymph nodes. There's no associated calcification, and they appear to be quite homogeneous, which would be in keeping with TB. There isn't any associated endobronchial lesions.
Okay, next patient, next case.
Okay.
So I'm going to comment the findings later on once I've done with all the cases.
This is a frontal chest radiograph of a child. The most obvious abnormality is expansion of the right hemithorax, which also appears to be translucent. My first differential would be a foreign body inhalation on the right-hand side. Other differentials to consider would include Swyer-James syndrome or Poland's syndrome. I would correlate with the history, and if there is concern for foreign body inhalation, recommend fluoroscopy or expiratory radiographs.
Expiratory radiograph.
Okay. So expiratory radiograph demonstrates air trapping in the right hemithorax, which would be in keeping with a foreign body inhalation. There is an impression of an increased opacity projected over the 6th or 7th rib, which may represent a radiodense foreign body.
Okay, Can we have candidate 2 now, please? Thank you very much, candidate 1 again.
Candidate 2, are you with us? Can you raise your hand if you are with us? Mani, let's go to candidate 3, please.
Yeah, no problems. No problems. Candidate 3, please raise your hand. Okay, lovely. Would you like to describe the abnormality, candidate 3?
We have a frontal chest radiograph of an older, although still skeletally immature child. The striking abnormality is some pulmonary opacification in the left mid to lower zone, causing obscuration of the part of the left heart border. I would like to correlate with the clinical history, but if there's an acute presentation, I'd be concerned about lingular atelectasis or consolidation. I think the findings would be in keeping with an acute infectious process and could recommend a follow-up chest radiograph after treatment.
Lovely.
So this is the frontal chest radiograph of a neonate. The lungs appear of normal to slightly reduced volume, and there are bilateral, diffuse, extensive granular opacifications throughout both lung fields. My primary differential for this, especially if the patient is a preterm baby, would be respiratory distress syndrome. That's it. Okay, so and if this is the same patient, so this is a baby gram, and just concentrating on the lungs, there remains some granular opacities, but the patient has now been intubated. There's an increase in the lung volumes, and some branching interstitial lucencies suggesting a degree of pulmonary interstitial emphysema formation.
Okay.
I could comment on the tubes and lines as within my general practice.
Yeah, sort of normal, so we'll leave that.
Reticular shadowing throughout both lung fields. I would like to know the patient's clinical history, but if they have a history of mechanical ventilation, this might represent bronchopulmonary dysplasia-like changes.
Yeah.
Sorry?
Ventilation. Patient is being ventilated at the moment.
Okay. Yeah. So I think there's reticular interstitial opacification with intervening lucencies, and I think this might represent bronchopulmonary dysplasia.
Okay.
We have another chest radiograph of a neonate. There is reduced lung volumes and increased opacification throughout the left lung, most notably the left upper and mid zones. There appears to be a degree of leftwards mediastinal shift, as this is a fairly centered radiograph. As far as I can see, the right lung looks quite normal, and therefore I think that the primary pathology lies on the left rather than overinflation on the right. I'd be concerned for either plugging of one of the left main or lobar bronchi, or bronchial atresia.
Anything else?
Well, this or it could be extensive atelectasis or collapse of the potentially of the left upper lobe. There's relatively normal lung in the left base at the costophrenic angle.
Okay, mediastinum.
I'm not getting, unfortunately the picture's a bit fuzzy, but I can see a normal looking right thymic contour. The left thymic contour is not very well displayed, but I think there might be underlying abnormalities in the adjacent lung. Overall, the mediastinum looks to be slightly shifted to the left.
Okay. Yeah, lovely. We'll discuss it slightly. Yeah, this one.
With quite large granular opacities. I would like to correlate with the clinical history, particularly if there is a history of birth, difficult birth. This could represent meconium aspiration. I would also like to know whether this is a term or premature neonate, because I think that it's also plausible that respiratory distress syndrome could appear like this.
Lovely description, yeah. Can we move, thank you very much, candidate 3. Can we move to candidate 4, please? Candidate 4, or if candidate 4 is not there, candidate 5?
Mani, just hold on please, there is a technical issue. I am trying to unmute candidate 4 is with us.
Yeah, I'm here now.
Okay. Yes, please. Would you like to describe this?
So I've got a frontal chest radiograph from what I can't see the epiphysis, so I think the baby is a premature baby, and the enlarged heart. The mediastinum is not, the superior mediastinum is not widened, so I've got an enlarged globular heart, and I can see that the pulmonary vessels are extending into the periphery. So there's pulmonary plethora, and the pulmonary arteries appear slightly enlarged as well. So this is a newborn, so I'm presuming this is a cyanotic congenital heart disease. With pulmonary plethora, I would be thinking about things like it does a transposition of the great vessels, or a total anomalous pulmonary venous return. And the other thing I'd be thinking would be of truncus arteriosus.
Which chamber is enlarged in this one?
It looks like all the chambers, but predominantly on the right side. So, but in someone with a cyanotic and pulmonary plethora, I wouldn't include pulmonary atresia in this category. So I'd concentrate more on a transposition or a total anomalous pulmonary venous return.
Okay. Yeah, we'll discuss it. And the last one probably out of the list before we go through all the cases. Yes.
So I've got a frontal chest radiograph in an older child. I can see there is a portocath projected over the right hemithorax, and I can see the heart size is normal, and there are increased the airways, there's a ring-like shadowing extending all the way to the periphery. So with the portocath and the bronchiectasis, I'm thinking this patient's got underlying cystic fibrosis.
Yeah. Yeah, we come to an end of the quiz, and let's go through these cases again. And in this one, some of the findings, the cardiac, this is situs solitus, apex is on left side, slightly upturned. Also the pulmonary artery appears slightly smaller, and the vascularity is sort of normal, but the aorta is on right side. So I'm just thinking that this is an operated tetralogy of Fellows. Okay, the patient is slightly older, so this is a case of tetralogy of Fellows who has been operated, but the findings are still there. The aorta will remain right-sided, but the vascularity has slightly increased, which causes confusion, but other findings are there. So this is a foreign body, and a coin-shaped foreign body, which is a coin actually. And so this is in coronal or end-on, so that means it is in esophagus. Had it been in trachea, it would be sideways. In trachea, it will not be like this in this orientation. So this is in upper esophagus, and the patient has to be referred for ENT for taking out the foreign body. The lungs are clear in this one. So this is a newborn, and a portable X-ray was done. There is increased lucency on right side, and the pleura is projecting to left side with shift of mediastinum to left. And this is a case of pneumothorax. And UAC is all right. This is optimum position. UVC appears slightly higher up and needs to be resighted or pulled out slightly. Nothing else is significant on this one. So in this one, there is bilateral lucency in the lungs, and thymus is well seen, which is normal for this age group. And because of the lucency, we know there is pneumothorax. The mediastinum is central. In this one, the cardiac shadow is all right. There is slight prominence of bilateral hilum. Also, paratracheal thickening is there, right, and widening of superior mediastinum. Not much is seen in the lungs on left side, but there is some streaky opacification in the right apex, which raises possibility of that there is parenchymal lung lesion. And we would like to do a CT scan. Also, the child is not very young child. So we would like to do CT scan, especially with these kind of findings, to know what exactly is going on. And as I showed you earlier, we see a cavitatory lesion with some amount of consolidation, fibrosis, and there is hilar and mediastinal lymph node enlargement. And this is most likely TB and needs to be correlated with the lab tests. And after treatment, this was the picture. So yeah, hilar lymph node have largely resolved. Also, the paratracheal lymph nodes have resolved. The consolidation also appears significantly less in comparison to the previous X-ray. So this was, there is lucency on right side with slight expansion and slight push of mediastinum to left side. And so like as it was described, we would like to consider a foreign body and do expiratory radiograph to confirm the diagnosis. In foreign bodies, because of the ball valve mechanism, there is trapping of air, and in expiratory radiograph, it is likely to increase. So the mediastinum shift is slightly more on expiratory radiograph, and the expansion is also slightly more. So we sort of confirm the diagnosis of foreign body. This is probably projectional, which was looking like a radiopaque foreign body. It is projectional, I guess. The rib and the pulmonary artery are actually overlapping. That's why it's looking more dense. And this was correctly described that there is there is haziness in left middle and lower zone, which is actually obscuring the left cardiac border, and it's typical for lingular consolidation. We may see some pleural effusion, and if the patient does not respond to treatment, then we definitely repeat the radiograph. But if they respond to the treatment very well, usually we don't try to irradiate them. And this indeed is a case of hyaline membrane disease. Lot of granularity is demonstrated, and also air bronchogram is seen because of haziness of the lung field. So there is haziness and granularity, typical appearance of hyaline membrane disease. And also the lungs are slightly hypoinflated. And after a few hours, the inflation of the lung is slightly more. We can see an ET tube. The UVC and UAC, they appear to be optimally sited. So this is PIE, and so if patients are intubated, or you get the history of intubation, please keep it high in your list. The appearances can be confusing, but if you see symmetrical lucencies and coarse pattern, keep it high on list. And if you see some lucencies, in this case, we can see some lucencies, and they are bilaterally symmetrical. And if I show you the previous, that's how it started actually. There were very subtle lucencies, and then it went on to this stage. And then if the settings are controlled, then they revert back. So I think this is the first X-ray of the patient. So this is a case of bronchogenic cyst. So this is the cyst which is there in the mediastinum, and it is compressing the left main bronchus, and also expanding the right lung due to ball-valve mechanism. So this is called doing too much actually to the lung. This is causing causing expansion of the right lung, and eventually the left main bronchus is getting compressed, which is causing partial collapse of the left lung. And yeah, that's how it started. It was small, and then suddenly it expanded, and it started with meconium aspiration syndrome, coarse opacities bilaterally, no significant shift of mediastinum usually, and it may be associated with pneumothorax, mediastinal air, and atelectasis. This was after about 10 days. Then these opacities, they largely resolved, and the lungs have expanded quite well. And this is a case of Epstein anomaly. It may be up the right side, that means right atrium is enlarged, and the pulmonary vascularity, to assess pulmonary vascularity, try to and we do so. Which blood test we do? Sorry, I don't remember. And that's it. Thank you very much for attention. And if you can fill the feedback form, that would be great.